Hey everyone, it's Dr. Mitchell. Let me turn this down. Frankie Valli, he's so good. So good. A little bit anxious because there's a rattle under my hood, and I just got mechanics to do some work on it. And they said it's sound for another 150k miles, but mechanics, yeah, they invoke a lot of anxiety in a lot of us, me in particular. So I wanted to share a case with you that will illustrate a lot of nice teaching points and hopefully better equip you to work with whoever you're working with in sorting out your health issues. So, where do I start? This is a young woman who was diagnosed with fibromyalgia. She has a very extensive history of having a lot of different issues since she was really, really young. Juvenile rheumatoid arthritis. Another clinician thought lupus. The one that she saw most recently before she came to me, someone I respect very much who really dropped the ball, said, you have nothing inflammatory going on, you just have fibromyalgia. Okay? And so first, let me talk about what fibromyalgia is a little bit. When we say inflammatory and non-inflammatory in rheumatology, what we really mean is autoimmune versus not. And it's not a really good categorization because at some level inflammation is going on, whether it's a little bit or a lot. And so don't think when you hear osteoarthritis is non-inflammatory, rheumatologists are dumb and they don't think inflammation is involved. It's just not a good categorization. So fibromyalgia, what is that? In a nutshell, you have the dials for pain perception turned way up. Okay, so we all have different baselines of that. They're just intrinsic attributes of you, me, John, Sue, whoever else, right? Think about linebackers or football players. Their dials are intrinsically way down and they have a higher pain tolerance. A lot of athletes do. And then some of us have much higher pain tolerance and don't touch us, basically. In fibromyalgia, something happens where the central nervous system is jarred and those are turned way up. And so if I'm doing a physical exam and I lightly apply maybe 5-7 pounds of force with my fingers, the patient flinches. That hurts. Sometimes you can't shake their hand, you can't give them a hug. It's really bad news bears for them, okay? But it's a non-inflammatory condition, meaning it's not immunologic. There's some studies that look at inflammatory cytokines, and there's a test out there looking at inflammatory cytokines suggesting that it is, but expert opinion is it is not. Some of the things that I look for, thyroid, SIBO, iron status, motor vehicle accidents, particularly affecting the cervical spine. That's some low-hanging fruit that should be checked in everybody. But anyway, let me get on to this case. So I already gave you some hints about this young woman. Juvenile rheumatoid arthritis. Another clinician worked her up, possibly lupus. The last rheumatologist she saw essentially said, you have fibromyalgia, go to pain management, which is a really bad idea for fibromyalgia patients because they may be prescribed narcotics, and that's not good because there's an entity called opioid-induced hyperalgesia in fibromyalgia, which means the narcotics can crank up the pain perception. So I reviewed all of her records, I looked at all of her lab work and everything, and there was a lot of interesting things going on suggesting that something inflammatory is indeed going on. Okay, she had a CRP of 17. CRP is C-reactive protein. Your liver makes that when there's inflammation. It helps with the cleanup crew when things get damaged and there's particles of you floating around. And so that usually tells me something more is going on. Again, if you take nothing away from this video, fibromyalgia with inflammatory markers, there's something else stewing, smoldering, or maybe it's overt that needs to be investigated. Okay? Symptoms. What did she come in with? Occipital neuralgia was what it was diagnosed as. She has this headache at the base of her skull that wraps around into her eyes. She's really tired. Gelsemium, homeopathic remedy. She didn't want to do the homeopathic remedy, so too bad. Inflammatory polyarthritis. Okay? Rheumatoid arthritis, lupus possibly, something else, who knows. Flank pain, right under the back of her rib cage. Okay? Renal involvement. She did have urinary symptoms. Photosensitivity. Okay? Rashes in the sun. Sun makes her profoundly fatigued. Oral ulcers. Pleuritic chest pain, which is pain when you're breathing. What else did she have going on? Generalized itching. Okay, we call that pruritus in medical speak. Am I leaving out anything else? Orthostasis, which is a keynote for dysautonomia, which we'll talk about in another video, but tends to track with fibromyalgia and different autoimmune diseases, and predicts really good response to low-dose naltrexone. I haven't been really impressed with naltrexone, but in those patients it seems to really make a difference. So the rheumatologist essentially told her, your CRP is elevated because you're fat, and he did use those words. You need to lose weight. You have nothing inflammatory going on. This is just fibromyalgia. Again, I've met this guy. I highly respect him. He's brilliant. So I guess it was the last appointment of the day, 5:47 p.m. He was supposed to be out of the office at 5 because he had a hot date at 5:30, and that wasn't going to happen for him. So doctors are humans too. We make mistakes. We get tired. We get worn out. And I would guess that that is what happened in him, because when I went through her records, it was very obvious to me something autoimmune is going on. And further investigation revealed that she had a liver biopsy. And the path report was equivocal, okay, meaning they didn't really know what it meant. But so I did some further testing. Her ANA came back positive. Her CRP went up to 17. She had some complements down and some indicators of renal disease. She had a smooth muscle antibody. What are smooth muscle antibodies? So you have smooth muscles in different parts of your body, GI tract, ducts. I can never say that word, ducts. Separate that C and T there. So not ducks that quack or are in the 1980s video game that was paired with Super Mario, where you have that dog that mocks you when you can't, shoot the ducks down. Duck hunt, that's what it's called. Not those kind of ducks. You make antibodies to this smooth muscle, and anyway, smooth muscle antibodies are characteristic of gastrointestinal involvement in an inflammatory disease, particularly autoimmune hepatitis. And I hear about this headache, and I hear about this pruritus, and I'm like, wow, she could have autoimmune hepatitis. Okay? Itching, generalized itching, is very, it's not a specific sign, but it makes us more suspicious of autoimmune hepatitis. And that small joint polyarthropathy and the fatigue and the photosensitivity, a lot of this is mimicking lupus, and there could be some lupus overlap, but again, these aren't specific signs, and that polyarthritis doesn't necessarily just mean rheumatoid arthritis and lupus. It can pop up in a lot of different diseases. And so at some point, maybe she should have been given azathioprine, which we also call Imuron, and maybe some low-dose prednisone, but that was never done. And instead, her occipital neuralgia was treated with Fioricet and codeine, which is acetaminophen barbiturate, narcotic, and caffeine. She was on that for 9 years. 9 years. So that's been a lot of our legwork here, trying to get her off of that. And so we've been slowly titrating her down, and she's at about 5% of her original dose. And you know what's happened? Some of her right upper quadrant abdominal pain and her headache's completely gone, and this has improved a lot. And so there's some interesting case reports on how acetaminophen can actually trigger and perpetuate the autoimmune process in autoimmune liver disease. So I'm wondering if once we get her off of that completely, a lot of this will just go away. But she's got a lot of other things that could be contributing. She has breast implants. I have a lot to say about breast implants and why most women should not get them removed. More on that later. We'll revisit that. But yes, this is clearly a case of she may have fibromyalgia. I don't completely disagree with that. She didn't really fit the picture or fit the questionnaire very well. a disease labeled non-inflammatory inappropriately that was actually inflammatory. Probable, very probable autoimmune hepatitis, smooth muscle antibodies, right upper quadrant pain, lupus-like features. We can't do a liver biopsy right now for reasons I'm not going to get into, but yeah. So if you take nothing away from this video, again, remember that fibromyalgia with the presence of acute phase reactants, elevated ferritin, CRP, erythrocyte sedimentation rate, or your SED rate, further investigation is needed. Something more may be going on. God, Frankie Valli is so good. Okay, this is Dr. Mitchell signing off. Hopefully you learned a little bit from this, and we'll talk again real soon. Bye-bye now.